for you. There's been a few IT sort of difficulties, but we'll do our best. And if you type any messages in the chat, we'll try and keep an eye on that as well. I think we're starting with Syed Schumann, who's a neurosurgical trainee from Newcastle. He says he's interested on his LinkedIn feed in jiu-jitsu, so we better listen to what he says.
Good afternoon, everyone. Thank you very much for this opportunity. My name is Syed Schumann. I'm one of the neurosurgical trainees from Newcastle. Today I'm going to present our project on recurrent laryngeal nerve palsy following ACDNF. As you all know, ACDNF is a common procedure undertaken to limit the progression of neurological symptoms and or relieve radiculopathy due to cord compression or nerve root compression. Recurrent laryngeal nerve palsy is a known complication of ACDNF with a quoted incidence of combined temporary and permanent recurrent laryngeal palsy of 7 to 24%. In addition to nerve division and postoperative edema, various theories have been proposed as to the intraoperative causes of recurrent laryngeal nerve palsy, including traction caused by retractor application. One theory is that the application of retractor during exposure of the vertebra causes stretching of the nerve base and nervorum, resulting in ischemia and recurrent laryngeal nerve palsy. Another theory is that the endotracheal tube, which is fixed at the mouth and trachea, is forced to bow when retraction is applied, causing direct compression and recurrent laryngeal nerve injury, which is followed up by supporting cadaveric studies. Other studies, such as Stewart et al., have shown that during the placement of retractors and application of traction, the ET tube cuff pressure can significantly increase from the recommended 20 mm of mercury to well above 100. Studies have shown a correlation between the excessive increase in ET tube cuff pressure and recurrent laryngeal nerve injury. In this report, we report our findings of the current practice in ACDNF preoperative assessment, intraoperative monitoring for recurrent laryngeal nerve injury, and the practice in the management of recurrent laryngeal nerve palsy. We conducted our study by an electronic survey which was distributed to neurosurgery and spinal orthopedic consultants via the SPNS and VAS. The questionnaire consists of 16 questions designed to establish the current practice of consent, preoperative assessment, intraoperative monitoring, and management of recurrent laryngeal nerve palsy. We received 185 responses, of which 95% were from consultant surgeons. Of the total responses, 64% were from neurosurgeons, 34% were from orthopedic surgeons. 59% of the surgeons said that they completed an average 16 to 50 ACDNFs per annum. During the consent process, we found that the majority of surgeons consented for a hoarser change in voice, and 48% consented for recurrent laryngeal nerve palsy. Preoperatively, the majority of surgeons do not routinely assess for recurrent laryngeal nerve function. Intraoperatively, 86% of the surgeons took a right-sided approach routinely. We also found that the majority of surgeons do not undertake intraoperative electrophysiology monitoring, ET2 cuff pressure monitoring, or adjustment of ET2 cuff pressure after applying retraction. 53% of the respondents stated that they had seen a recurrent laryngeal nerve palsy following an ACDNF, of whom 58% referred to ENT, 34% observed the patient, 30% referred to a speech and language therapist. Of those who referred, 42% referred only when symptoms persisted, whereas 39% referred early on. When asked about perceived barriers to ET2 cuff pressure monitoring, cost, equipment, and time pressures are all variably ascribed as to why surgeons do not use cuff pressure monitoring. These are some of the free text comments we got regarding the perceived barriers to ET2 cuff pressure monitoring. We know that recurrent laryngeal nerve palsy is a rare complication, but it is a recognized complication. Some of these are some of the comments that we got. To us, it may seem like it's a rare complication or that it has never happened to us, but it can happen, and when it happens, it can affect patients significantly, so it's worth thinking about and taking steps to prevent it. So what we have found is that in the UK, ACDNF practice is fairly uniform, with the majority of surgeons consenting for similar complications. Most surgeons do not routinely assess the vocal cord function preoperatively. Most surgeons do a right-sided approach and do not do intraoperative monitoring for recurrent laryngeal nerve injury. We also found that surgeons felt that it was a rare complication, and some felt that they did not need to monitor for recurrent laryngeal nerve injury. Looking at the literature, we found that there was good evidence to favor a left-sided approach. The right-sided recurrent laryngeal nerve is shorter, travels outside the tracheoesophageal groove, and is more oblique than the left. This leaves it more susceptible to stretch and compression injury, according to some studies. Intraoperative neurophysiology monitoring didn't have any good evidence to support it, Studies such as Jalish et al. Found that EMG activity correlated with insertion retractor, but not the clinical outcome. Deflating inflating cuff pressure, however, does have good evidence to support it. What we have been doing in Newcastle, we find is a very cheap and effective method of monitoring ET tube cuff pressure after applying retraction is simply by connecting the ET tube cuff to a pressure monitor. The anaesthetist already measured the cuff pressure on intubation, so they already have the equipment to do this. All you need is a little bit of tubing to extend the cuff port so the anaesthetist can measure it intraoperatively without disturbing the surgical field. They can then adjust the cuff pressure accordingly after applying retraction and again after releasing retraction and adjust it accordingly. The anaesthetists are in favor of this, as we have found that when applying retraction, the cuff pressure can significantly increase 2 to 5 times above the recommended cuff pressure value. Thank you very much for your time. These are my references.
Thanks very much, Syed. Laura, are we able to pull Syed into the presenters so that he can answer questions now? I mean, one question I'd maybe put to you, Syed, while you're being dragged in. It's a nice presentation. Do you think you should be disseminating this information amongst the anaesthetic community, therefore, rather than presenting it to the surgeons?
Can you hear me?
Yeah, we can, yeah.
Yeah, I absolutely agree. We find that our anaesthetic colleagues are very in favour, and they were very willing to try and get involved with this project. And they said the same thing as you have, that we should distribute it through the anaesthetic team. We've got a team here who we're in chat with, and they're going to think about distributing it, or jointly distributing it to the anaesthetic side of things as well.
Syed, I certainly had a chat with some of my anaesthetic colleagues today, and certainly they're quite comfortable employing this procedure because apparently they routinely use it in ICU to check cuff pressures in intubated patients.
That's correct, yeah. In our theatres as well, especially with Mr. Nissen that I work for, he routinely does this, checks the cuff pressure, and the anaesthetics team routinely now do it for him, and they're very in favour of doing it.
Do you notice that perhaps Mr. Nissen's recurrent laryngeal palsy rates are much lower? You're doing an audit on this that you could potentially provide data on?
We were looking into it. We were going to look into what steps we take next and what evidence we have, or collect the evidence before we make some sort of suggestion. But yeah, I don't know what his recurrent laryngeal nerve palsy rates are at the moment, but this is something we need to look into, yes.
We've got a couple of questions from the floor. Firstly, from Ed Seal. Do you know the rate of recurrent laryngeal nerve palsy in non-cervical spine surgery due to the cuff alone? And Neil Orpan's just put into that then, do you think surgical time might contribute? And Mark Thomas has asked, when would you recommend a referral for investigation? Is it 6 weeks, 3 months, immediately? When would you ask people to see it?
Yeah, so there have been papers out especially by Kirkovich and Afrodam, who have shown that recurrent laryngeal nerve palsy can happen in surgery not including the neck or the thorax. Therefore, that's why they hypothesized that the endotracheal tube cuff pressure is actually one of the causes for recurrent laryngeal nerve injury. So yes, definitely non-neck surgery can cause it. And the other question, sorry, you said?
When do you recommend referral for investigation?
At the moment, it varies amongst consultant surgeons when they refer for follow-up with SALT or ENT. What the literature has shown at the moment, people tend to follow up their patient at 3 months, and so most of the recurrent laryngeal nerve palsy are temporary, and most of them recover. I think one of the studies has shown that at 3 months, initially there was about 6.5% recurrent laryngeal nerve injury paresis. However, when they followed up at 3 months, it went down to 1.3%. At the moment, I wouldn't have the evidence to say when to recommend, but at the moment, it looks like waiting for 3 months, seeing how they recover would be an appropriate step.
That's very helpful. Thanks. So we'll probably better move on to the next talk.
Thank you very much.
Thank you very much for an excellent talk. The next talk, I think, is coming from Spain. Helios is a biomechanical engineer from the University of Valencia, and has projects on healing and in age. So he's going to present on integrity tests for assessment of whiplash-associated disorders.
Good afternoon to the participants in this session. My name is Elios de Rosario, and I am a researcher from the Institute of Biomechanism of Valencia, and I want to present a study made in collaboration with the University of Padova and the Spanish insurance company MAS as part of the Horizon 2020 project backup, with the purpose of developing a method to test the integrity of the response of patients with whiplash-associated disorders. The motivation of this study is the concern that exists in the context of whiplash, especially when there are litigations and possible insurance compensations of having patients that exaggerate their pain and disability. This is a controversial issue since it is difficult to judge the patient's intent, and in this regard it has been recommended to evaluate potential malingering by checking different types of evidence, starting from the existence of external incentive and the absence of psychological disorders, and continuing with the results of physical evaluation, neuropsychological tests, and self-reports. In the study that I am presenting, we try to take into account all these aspects, using the two former as the inclusion and exclusion criteria. So what we made is an observational study recruiting patients from hospitals in Italy and Spain, which were classified in three groups. First, controls, which were normal whiplash patients, then false patients, which is former patients who were already recovered but were asked to behave as when they were feeling pain, and the third group that we call biased, which had the same inclusion criteria as the group of patients, but two independent evaluators judged them to be suspicious of feigning or exaggerating their symptoms. Then, all patients went through three different types of tools that have been used before to evaluate possible malingering, or at least suspicious pain behavior, as published in the given references. Going straight to the results, the exploration of data and ANOVA tests showed that there were significant differences between groups in the results of the symptoms questionnaire and also in the psychological variables, but not in the neuropsychological test, the AIIT. Then, we fitted a linear discriminant model to distinguish between those groups, choosing variables with the maximum influence on groups, but the smallest correlations between them. And in the end, we obtained a model that combined two parameters from the symptoms questionnaire and two from the biomechanical tests. As may be seen in the sign and size of the model coefficients, the principal linear predictor, the one in blue, was positively related to the accumulation of reported symptoms, both possible and rare, and also with slow but regular movements with smaller velocity and greater face area ratio. And on the other hand, the second linear predictor increased when the proportion of reported possible symptoms increased with respect to the proportion of rare symptoms, whereas the biomechanical parameters did not play an important role in that. This plot on the left represents the values of the first and second linear predictors for the measured subjects, where the colors represent which cases would be considered to belong to the first group or the others. And it may be seen that the group of people asked to fake previous symptoms overlapped the other two, those triangles, especially in the group of suspects, but normal and biased patients, represented by circles and crosses, were rather different from each other. The binary classification between suspects and non-suspects patients was not bad, nearly 85% of specificity and 78% of sensitivity, and in a cross-validation, the average area under the curve was equal to 0.84, which can be considered excellent classification. In conclusion, we obtained that the combination of self-reported symptoms and the results of motion tests may provide useful information for spotting out inconsistent or potentially feigned response of whiplash patients. also that our results were conservative with greater specificity and smaller sensitivity, in which the flags that indicated possible feigning was slow but regular neck motion and accumulation of reported symptoms and a greater proportion of rare symptoms. Also, we found that contrary to intuition, the suspects were more distinguishable from non-suspect patients than fakers. And a possible explanation for this is that the suspect group was chosen by subjective assessment and agreement by 2 examiners, so there might have been a selection bias that narrowed down the profile of that group. So thank you for your attention. If you are interested in these results and this work, this is the website of our project where you can find more information and also contact with us. Thank you.
Thank you, Helios. We seem to have lost Senthil into the crowd, as it were. Laura, could you drag Senthil and Helios in to answer any questions? Just in the meantime, while that's happening, Helios.
Helios is here ready to answer the questions. He just needs to turn on his mic. There you go.
Okay, there's none typed from the floor. Yes, so maybe if I ask them a question. We know from certain nations, such as New Zealand, where no-fault compensation is in place, that there is a different pattern of presentation, at least for whiplash-associated disorder. Do you think that the actual the legal framework of the environment that you perform your research influences the outcome and therefore your recommendations?
Yeah, sure. Can you hear me? Yes. Okay.
Yeah, we can.
Sure. It's completely true, and it's something that we observed in the framework of the project. That this is an issue that depends a lot on the legal framework of the countries that participate. In this case, we found that, for instance, in Spain and Italy, although legally it's different, in other circumstances there are similar conditions. But in the backup project, for instance, there are many other countries participating from Europe where the framework is completely different, and even the problem of this problem is not really a relevant one. The problem may be the opposite one. And in some tests or explorations of the issue that we have made, we observe very different results. So this is really conditioned to culture, legal framework, and other conditions, not only the situation of pain, of course.
Okay. Thank you very much, and thank you for the interesting paper. I still can't see Senthil in the room, Laura. I don't know if there's a problem dragging him in. But I don't have any other questions from the floor, so possibly if we move to the next paper, which is from Joseph Davids, who is a doctoral student at Imperial College, Queen Square, and works with nanoscience, nanotechnology, and AI.
Good morning. I'm Ravi Vasagan, one of the neurosurgery registrars in London. The title of the talk today is Surgery for Cervical Spondylotic Myelopathy Produce Improvements in Function, Findings of the BritSpine Registry. This is work from the Department of Neurosurgery, King's College Hospital in London. There are no funding or conflicts of interest to declare.
Hello,
The objectives of our study were to evaluate national spinal surgery practice in the UK, the degenerative cervical spondylotic.
I'm here to talk to you about the effects of ligamentum flavum on buckling on indirect posterior cervical decompression in our center retrospective cohort study. Work done at Queen Square and the Royal National Orthopaedic Hospital 2 years ago. So circumferential cord compression is a relatively common cause of compressive spondylotic myelopathy, with an incidence of about 4 per 100,000. The gold standard management is surgical anterior, posterior, or combined cervical decompression. And we asked the question, actually, can we manage circumferential compression from an anterior approach only, or can we have indirect decompression posteriorly? So we aim to identify and quantify the indirect posterior cervical decompression in patients with degenerative cervical myelopathy who has circumferential pathology across these two sites. And from the two sites, we identified consecutive patients with cervical myelopathy over a period of 10 years, patients who had undergone anterior cervical approaches receiving anterior cervical decompression secondary to circumferential pathology. And we used the T2 weighted MRI scans pre and post-operatively to perform measurements, which was then verified by the radiologist and neurosurgeon. The primary outcome was whether or not there was radiological evidence for posterior indirect decompression. So how did we do our measurements? Well, mid-sagittal scans were then taken, and as you can see, the posterior intervertebral body line, which we took as the highest point of the superior vertebral incisor of the body to the lowest point of the inferior vertebral incisor of the body, was drawn. We then drew a corresponding interspinous line from, again, the superior anterior spinous point of the body above to the corresponding on the body below. And then a perpendicular line was then drawn to touch the point of maximal cord compression. And that was also done for the posterior side. Height restoration was also measured as inter-end plate height, measured as the apex of the inferior end plate dome of the vertebral body above to the lowest concavity of the superior end plate of the vertebral body below. Statistical analysis was done using SPSS, and a multivariable logistic regression was then performed to identify those who failed posterior decompression post anterior spinal surgery. Significance was set at the p-value of 0.05, as we generally do in research. So 87 consecutive patients identified, an average age of 61 years with a greater male to female preponderance, which is reflective of what is reported in the literature. 120 levels decompressed. Corpectomies were excluded. There was about 6 of them. And this was the distribution for multi-level ACDFs. So our results, as you can clearly see here, for both pre-op and post-op comparisons show a significant improvement in AC and PC as well as height restoration. This led to indirect posterior decompression achieved from anterior spinal cord decompressive surgery in about 78.3% of our levels. Inter-rater agreement was reasonable, with the expert neurosurgeon and neuroradiologist both agreeing, and there's also intra-class reliability measured here as well, with a correlation of about 0.04, but still significant. So subgroup analysis for those who actually failed showed that actually 20% had no change, 1.7% had a worsening, and our multivariate logistic regression model presented spondylolisthesis as the only factor for failure of indirect posterior decompression for anterior spinal surgery. Other risk factors we had were multiplicity of surgical levels, failure of index level height restoration, which we define as around less than 2 millimeters. So in conclusion, degenerative cervical myelopathy secondary to circumferential spinal cord compression is a common clinical scenario. Anterior cervical decompression is an effective strategy to manage this, and we've shown this in at least 78% of our cases. The presence of spondylolisthesis is a risk factor for failure of indirect posterior decompression, and we have provided the first evidence from our study for ligamentum flavum unbuckling in patients with circumferential spinal cord compression.
Thank you, Joseph, for a very interesting study. Is Joseph in the room and able to comment on questions? Anne Mannion has asked about your kappa value for inter-rater reliability. If you could bring that up. She feels it's not that high. I was going to ask a question also about possibly the use of CT here and whether or not ossification of tissue has any effect. Or there's also a question about if there's any difference if you actually reduce the spondylolisthesis, if you found that as a risk factor.
Paul, I can't see Joseph on the chat, but I can see one of his colleagues.
Okay, are we? Who's in the room?
Kia? Mr. Kia Residue?
Kia, are you able to answer on Joseph's behalf? Okay, Kia is just saying that his audio's not working, unfortunately. Kia, are you able to type in the chat any answers to those questions? Maybe firstly, Anne's question about the kappa value. If you type it in the message, then I can read it out if it only comes up for us.
Sorry to interrupt, but I've been asked that we move on to the next talk. So perhaps we could come back to the questions afterwards. Is that okay?
Okay. Yeah.
Yeah, I'm happy with that. I think it's a very interesting topic that would be nice to come back to.
Yeah. Okay, so the next talk is from Ravi Visagan, using the BritSpine registry. Ravi's from St George's, and he's going to be talking about some of the findings of the BritSpine registry, looking at the outcome in function after surgery for cervical myelopathy.
Good morning. I'm Ravi Visagan, one of the neurosurgery registrars in London. The title of the talk today is Does Surgery for Cervical Spondylotic Myelopathy Produce Improvements in Function? Findings of the British Spine Registry. This is work from the Department of Neurosurgery, King's College Hospital in London. There are no funding or conflicts of interest to declare. The objectives of our study were to evaluate national spinal surgery practice in the UK for degenerative cervical spondylotic myelopathy by using the British Spine Registry. We evaluated the demographics, type of surgical approach, and one-year outcomes of patients undergoing surgery for cervical spondylotic myelopathy. CSM is encountered in a spectrum of healthcare settings, leading in some cases to cord compression in the clinical syndrome of cervical myelopathy. The disease course is variable, with some remaining stable over time, whereas others experiencing a stepwise decline in function. Surgery aims to arrest neurological decline by decompressing the spinal cord and also to restore normal alignment where appropriate. The approach is dependent on age, symptoms, number of levels involved, foci of compression, alignment, instability, and surgeon preference. There is evidence in the literature that preoperative factors correlate with a poorer outcome: symptom duration, severity of myelopathy, and cord signal change. Old age, diabetes, obesity have less consistently shown a robust association. This was a prospective observational cohort study where we included all CSM patients undergoing surgery with a complete pre- and post-MDI score recorded at 1 year. Our primary outcome was change in MDI score. We performed further subgroup analysis and self-organizing map clustering analysis to identify any correlations. That is, to examine whether subgroups within a sample with particular characteristics differ significantly in their postoperative outcome. We used Cohonen SOMs and hierarchical clustering. An SOM, or self-organizing map, is a machine learning algorithm based on neural networks to visualize patterns in multidimensional datasets. The MDI is the primary PROM and functional assessment tool in CSM for the BSR, originally developed for rheumatoid arthritis and later for CSM. It measures 10 ADLs within 5 domains: rising from the chair to bed, walking, eating, hygiene, and grip. Each ADL is scored on a scale of 0 to 3, 0 to major disability, with a maximum score of 30. 525 patients met the inclusion criteria were identified from the registry. The summary of demographics is demonstrated in this table. The majority of the sample underwent an anterior approach for CSM. Overall, the postoperative MDI score at 1 year was less. Specifically, 58% of patients had improved MDI scores at 1 year. This amounts to 303 patients showing improved scores at 1 year after the operation. When examining for gender differences in change in MDI scores, there was no significant difference between genders, as you can see from this figure here. Likewise, when examining for age differences, again, there was no statistically significant difference between age groups. SOM analysis derived 5 major clusters with similar characteristics in our population. A shows a Cohonan depiction of the population where each node contains 4 to 45 records that are extremely similar in age and gender. Each node is shaded from white to red, with darker colors representing higher average values for a given variable. Subfigures B to H show the distribution of a single variable across the SOM grid, using colors to depict values. This busy slide summarizes the cluster analysis, but essentially there are 5 clusters that were identified by our trained neural network, highlighting intrinsic demographic and surgical characteristics. It is interesting to note that the most improved group was cluster 4. This is characterized by significant disability pre-op, MDIs of 30, improving 16 points post-op at 1 year, a female preponderance and relative balance between anterior versus posterior approaches. To conclude, this is the first time that the surgical practice and outcome in CSM has been evaluated using a national database in the UK, the first time an artificial neural network has been used to perform a cluster analysis on a cohort like this. One of the disadvantages of artificial neural networks is the lack of clarity into how a trained algorithm can derive its clusters, i.e. a retrospective factor analysis. The other limitation of our study is looking purely at delta MDI, which represents a binary outcome. In reality, clinically meaningful differences are a better patient-specific evaluation of whether surgery does produce functional improvements. And this is what we are currently performing on our cohort to better understand what factors correlate with improvement or worsening after surgery. Thank you for listening.
Thank you very much, Ravi, for the talk. It sort of, in a way, looks like a work in progress still that you're still working on, and I hope you bring the future results back. Have we got any questions from the floor? I can see Anne's typed one in. What's the questionnaire return rate or compliance with questionnaire completion for your patients in the BSR? Hi, Ravi. Are you able to talk to us? I can hear something.
Can you hear me?
Yeah, we can hear you, yeah.
Sorry, I was just going to say, unfortunately, I don't have the actual value of compliance to hand.
Okay.
I've got a question, Ravi. Do you get a feel as to which patients do better for regards to the anterior approach? Because it's always a debate in Leeds, certainly.
Yeah, this is the thing we're trying to better understand, really. We didn't, in the first initial phase of this, do a kind of multivariate analysis of all the factors, but we're certainly doing this moving forward. I think it's going to be interesting to look at that, because in the sample that we used, there were certainly a leaning towards anterior approaches versus posterior approaches. So we're hoping to have that data for the future.
Is this across all age groups or?
Yes.
Okay, so David Bell, I think, has come in to answer the question that you couldn't. He says that 40% of the patients pre-op have PROMs and 46% of post-ops. I'd sort of maybe ask a supplementary on that is, do you have any administrative support for BSR, or do you just rely on surgeons and POAC nurses putting it in?
We do have an administrator. Certainly at King's, there's a BSR administrator, and also all the registrars are trained on how to input data into the system.
Okay. Anne's also asked a supplementary there. It says, in relation to improvement, 58% is pretty low for any improvement in score, if that's what this figure reflects. What do you estimate is likely to be the percentage success seen for, open inverted commas, a clinically relevant improvement, close inverted commas?
Yeah, thanks for that question. That's very relevant, and it's exactly what we're planning on doing. So we're trying to use the minimum clinically important difference to try and answer that. We understand this is quite a crude marker, just looking at the change in MDI, but certainly this is what needs to be done to really understand at patient level, because small changes in the MDI may be different for one patient, which can produce clinically meaningful improvements in function.
Okay, thanks. So we've got about 7 minutes left in the session, so I think we probably better move to our final speaker, who's Ben Grodzinski, who's a final year medical student, I understand, at Christ College, Cambridge. I can't see the number on the I think this is the correct one.
I'm Ben Grodzinski, presenting at BritSpine 2021. The talk I'll be presenting is entitled, Can Co-Authorship Networks be Used to Predict Author Research Impact? A Machine Learning-Based Analysis of Degenerative Cervical Myelopathy Research. Degenerative cervical myelopathy, or DCM, is a neurological condition defined by symptomatic spinal cord compression. It is common, affecting over 2% of adults, and has a significant impact on patients' quality of life. Despite this, awareness of DCM amongst both healthcare professionals and the general public is low, and many research questions are yet to be answered. To combat these issues, the BritSpine Recode DCM project utilized a consensus process involving both healthcare professionals and patients to identify the top priorities for DCM research, which are shown here. Having established these priorities, the next step is adoption of the priorities by the research community, a process known as knowledge translation. One of the recognized mechanisms for knowledge translation is identifying so-called agents of change, key individuals with a high research impact who are therefore well positioned to distribute findings to a larger but relevant audience. The challenge is, how do we identify these agents of change? Here, we present a novel method for identifying agents of change using co-authorship networks. We hand-built a database of all primary clinical trials in DCM from 1995 onwards, and used the list of authors for each paper to create a visual representation of the DCM research community. Within this network, each dot, or node, represents an author, and the lines, or edges, between them represent co-authorship, i.e. that they were both authors on the same paper. The colors represent the authors' countries. So, how can we use this network? Firstly, it can give us information about the structure of the DCM research community. For instance, we can see on this zoomed-in section of the network that authors tend to gather in clusters, representing research institutes. Collaboration between clusters is good, but collaboration across national borders, shown by the different colors, is poor, with relatively few international co-authorship links. Secondly, it can give us information about the place of individual authors within the network. For each author, we can produce metrics such as their first degree and second degree connections and their betweenness, which is a measure of how crucial they are to information flow within the network. How can we use these network metrics to identify agents of change? Well, given that agents of change are individuals with a high research impact, we can reformat our question to ask whether an author's network metrics can predict their research impact. For this, we need a quantitative measure of how impactful an author's research is, something to compare against. For that, we used H-index, a commonly used metric, which encompasses both an author's number of papers and the number of times that have been cited. In order to turn the network metrics into an impact prediction, we used a neural network model. This takes the network metrics for each author and compares that to the author's H-index to work out which network metrics are predictive of author impact. This neural network was trained on 80% of the authors from our original database, then retrospectively validated against the remaining 20% to see if it could predict their H-index solely from their network metrics. And it turns out that yes, the neural network can predict author research impact solely from co-authorship network metrics. And while it was trained on the H-index, the same methodology can be used to predict any impact metric. We were also able to ascertain the network metrics that particularly contributed to a high predicted research impact, shown here. We found that authors who collaborate either in small or very large groups and who collaborate with well-connected authors are likely to have a high research impact. This emphasizes the importance of collaboration within DCM research. All of this helps us to identify who the current agents of change are within the research community. Our next step is to take these findings and apply them prospectively to see if we can use our network model to predict who the future agents of change will be. Thank you very much. Here are my references, and I would welcome any questions.
Thank you, Ben, for a very thought-provoking talk to finish the day off. It'll be interesting to see what the outcome would be if you applied your metric to COVID-19 research. You might get a few more international ties there, and also interesting to see whether you can break it down to households and husband and wife researchers collaborating as well. That might be interesting. So, I haven't got any questions coming through from the floor at present. Is there anybody out there who wishes to ask a question?
I must commend the Cambridge unit.
BritSpine 2021. The talk I'll be presenting is entitled.
Sorry, don't know how that happened. Sorry. Who was speaking?
Oh, it's central. I just want to say, commend the Cambridge unit in collaborating with the Toronto group through Michael Failings in further research into myelopathy. Certainly, they are successfully managed to secure NIHR grant recently in looking at myelopathy, laminectomy versus laminative fusion for multi-level spondylomyelopathy. And certainly, it's thanks to Mark Cotter and Ben Davis' collaboration, certainly helped secure that funding. So watch this space.
Absolutely, thank you.
I see Ed Seal is typing a question. Hopefully that's going to come through. So Ben, once your AOC are identified, how do you think it will make a difference?
Yeah, so that's the crucial question, isn't it? And I think the idea here is that we want to disseminate these research findings, and we want to try and get the priorities which we've spent so much effort identifying to be researched. And the way that we do that is by having a kind of idea of who's doing the research, and then kind of gently pushing people towards saying, actually, this is the kind of research we should be doing. Because currently a lot of the research in DCM, as in fact demonstrated by some of the talks today, it's very surgery focused, which is understandable because it's done by neurosurgeons and orthopedic surgeons, so fair enough. But actually, when you look at what patients want to know about DCM and how that's reflected in the priorities, actually we need to diversify our kind of research output. And so the idea is that by identifying these agents of change, the people who are kind of already producing high research impact, they are in a position to A, start researching other things themselves, and B, to kind of disseminate and help to promote these priorities so that we're not just kind of standing here waving our own little flag, that it becomes more accepted in the research community as a whole.
Okay. Thank you very much. Well, we've come to the end of the session. An interesting session. Sorry about any technical difficulties, but we're all feeling our way through the system. I'd like to thank all the speakers for submitting talks that fitted to time, and the patience of the participants with our technical difficulties. I thank Laura and Henry very much for the support in this new system that we're all trying to grapple with. And I would say normally it's off to the bar, but I presume it's off to your home drinks cabinet, and hopefully we'll see you all tomorrow. Thank you very much.
Thank you.